will now hand over to our first presentation, which is Dora, who's going to talk to us about our systematic literature review, which was the first thing that we started with. Thanks, Dora.
Hello, everyone. Good to be here. So I'm Dora Stefanidou. I'm a research fellow at the Division of Psychiatry, and I worked at the MIMOS study with Liz and the team throughout the study, so for 3 years. And today I will be talking about work package 1, which is the systematic review. So I think I'm sharing my screen. Is that right? Yeah.
Yeah, brilliant. We can see that fine, Dora. Thank you.
Lovely. So our review was about the identification and treatment of mental health and substance misuse problems in sexual assault services. And so that was an international review, and we aimed to examine the international evidence on what is available regarding mental health and substance misuse provision in sexual assault services. And to our knowledge, this is the first, or at least it was the first review examining this topic. So we had 3 review questions. Review question number 1, what are the approaches to addressing mental health and substance misuse problems in different sexual assault service models? So again, we didn't just look into the UK SARCs, but we looked into the international literature. So what models of care in sexual assault services are effective regarding service users' mental health and substance misuse outcomes? And finally, what are the stakeholders' views and policy recommendations about how sexual assault services should address the mental health and substance misuse needs of service users? So what is it that we did? So we searched 4 electronic databases from 1975 up to August 2018. And we chose the 1975 as a date limit because the first sexual assault service model was established in the mid 70s in Australia, I think. And we also looked for grey literature. So we ran a web-based search, and we looked through conference proceedings, government documents, to find policy documents. And we have different eligibility criteria for each of our review questions, but very generally, we included papers that talked about sexual assault referral centers or equivalent services. So we defined that as specialist support services that exist in a single service, and they provide forensic medical examinations, and they also have healthcare provision. And we excluded non-SARC services and SARC services that they don't provide any information on mental health or substance misuse. So what is it that we found? So we included 107 full texts, and some papers were relevant to more than one review questions. The included papers were published between 1979 and 2019, and they covered services around the world. So I will now talk you through briefly the findings for each of our review questions. So for review question number 1, we looked into the approaches to mental health and substance misuse within the sexual assault services. So we identified 78 papers published from 1979 to 2019. And we identified 3 domains of mental health care. So identification of mental health problems and substance misuse, in-house support, and referral to other helping agencies. And within those domains, we distinguished different approaches. So within the identification domain, we have clinical judgment, structured standardized assessments, and use of validated measures. Within in-house support, we have immediate emotional support at first contact only, counseling, which is mainly unstructured, psychological interventions, so manualized, structured, evidence-based interventions, and finally, unspecified support. And within the domain of referral, we have signpost and refer, but also refer with active follow-up. So when the staff actually check with clients whether they engaged with the other helping agency. The most popular approaches were identification based on clinical judgment, so no use of structured ways of assessing whether people have mental health and substance misuse needs. Within the in-house support was counseling. So again, that was unspecified and unstructured. And the most popular approach for referral was signposting and referring, but without any active follow-up. It should also be noted that the child advocacy centers in the America and Turkey, and also the sexual assault centers in Nordic countries, were the most likely to provide structured mental health support. So assessing using standardized measures, using valid evidence-based psychological interventions, and referring onwards to external services with active follow-up. So the second review question was about evaluating psychological interventions for people attending sexual assault services. And we found 6 papers reporting on findings of 5 studies. These were all randomized controlled trials, 4 in the US and 1 in Australia. Andrea, I'm not aware of the time, so if it's taking long, just please let me know. And so 4 studies examined brief video interventions before or after a forensic medical examination. And basically those interventions provided information on what would happen at the forensic medical examination, but also psychoeducational material about self-management to prevent post-assault distress and substance misuse. And then we had only 1 study looking at cognitive processing therapy. All of those interventions in all of these trials were compared to standard care, and the assessed outcomes were substance use and abuse, anxiety, depression, and PTSD. Now, what did the study find? So 2 studies reported positive effects for the video interventions on reducing risk for marijuana abuse and anxiety symptoms at follow-up. However, we basically found mixed evidence of moderate quality because the studies had significant methodological shortcomings, so small sample sizes and high attrition rates. And finally, we looked in stakeholder views. So what did the stakeholders think SARCs should do and should provide for service users in terms of their mental health and substance misuse needs? So we found 32 studies from published between 1980 to 2018, basically across the world, as you can see. And I have summarized here the main recommendations from stakeholders. So they think that SARCs should have a systematic way of assessing mental health and substance misuse. They should also provide in-house counseling and psychological support. They should have clear referral pathways with active follow-up. And they also highlighted the need for specialist training for the SARC staff. So the SARC staff should be trained in mental health and substance misuse, but also specialist training for the needs of LGBTQ people and people with learning difficulties. And finally, we looked into policy recommendations. We identified 10 policy documents, so 6 from the UK, 3 from the European Union, and 1 was a research study commissioned by the Home Office, again published from 2004 to 2018, and a summary of the main recommendations also here. So the policy documents suggested some assessment of mental health and substance misuse. Now, that is as generic as it was, in the policy documents. It was not really specified what this assessment should look like, but it should take place. They also said that referrals should take place to community mental health teams and acute mental health services when clients' needs are greater than IAP level 3 support. Now, again, what would happen for clients below that severity threshold within the SARCs? We don't know. It's not specified. There was a complete absence of guidance about substance misuse, and this is something that we found overall in the literature, also in the empirical studies. They also suggested that CBT should be provided for clients with PTSD, again, specialist support for LGBTQ people, and counseling to friends and family of SARC service users. It should be noted that because of limited resources, we mainly looked into the UK policy rather than the international policy. So we might have missed some important points here. And so to bring my presentation to an end, some limitations of our review. So many of the papers we included did not really aim to investigate sexual assault services in relation to mental health and substance misuse. And so that means that large variations in care might have been masked. We believe that this might actually also reflect the fact that mental health and substance misuse are not seen as core areas of activity within sexual assault centers, compared to their more defined roles as forensic evidence gathering and physical healthcare services. And so the variation of care was so large that it's almost like a postcode lottery for service users, because you don't really know what you're going to get depending on the location of the service you're going to attend. The empirical studies we found had, as I said, some weaknesses, small sample sizes, high attrition rates, so findings are not conclusive. And finally, within the stakeholders' views, we had only a handful of studies on service users' perspectives. So we're really missing those voices. And the policy guidance, as I said, was limited to England. So just a summary of what was talked before. And I think what needs to be highlighted as well is that there was a real lack of specificity in policy guidance. So again, it's all very generic. Sexual assault services should do something to assess mental health needs and substance misuse. They should provide something, but nobody knows what that should look like. So there is an urgent need for high quality evidence to inform service development and studies to explore the views of service users, including seldom heard groups like LGBTQ clients and clients with learning difficulties and people from ethnic and minority backgrounds. So thank you. Yeah, just also to say it was a great pleasure working with Liz and the team on this study. It's felt really important, and we believe it is. So this is a link to our published systematic review if you want to read the whole thing, and you can contact me or our Mimos email address in case you want to know more about our review or have any questions. Thank you.
Thanks very much, Dora. That was great.